Good morning, everybody. So, how many people have we managed to get here? Ooh, about 20. Well, congratulations. Thursday morning, 7 o'clock. You're heroes. How many people were here over the weekend courses? Anyone? Wow. Gold medals all round, I think. Anyway. So here we go. You're nearly at the end. So, added value of MRI in patients with DSDs. So, DSDs are disorders of sex development. I have no conflicts of interest to declare. So what is a DSD? I think that we as imagers, many people actually don't understand that the term DSD has now replaced the term intersex. And this has happened because a lot of the intersex terms are quite pejorative. They have terms which really make you sound like, a half person, you're between one sex and another, and certainly patient groups really did not like the terminology. So in 2006, Professor Hughes led a consensus group and a paper was published in which all the definitions of intersex were reclassified, and it's now called DSD, disorders of sex development, defined as a congenital condition in which the development of chromosomal, do you want to start the timer? You start it, okay. So it's a congenital condition in which development of chromosomal gonadal or anatomical sex is atypical. So this is how the terminology has been revised. So we have the previous definitions with intersex, male pseudo-hermaphrodism. You can imagine that if you were a male pseudo-hermaphrodite, you'd find that a pretty unpleasant name. And they've now been called sort of non-judgmental names. So we have 46XY DSDs, 46XX DSDs, and so on. So examples of these. So examples of the 46XX DSDs are disorders of gonadal development, including the ovotesticular disease, DSDs, streak ovaries, disorders where you have androgen excess, and then the other group of disorders, which includes cloacal anomalies and the majority of the Müllerian anomalies, which I'm mainly going to be talking about today. So 46XY DSDs are things like Swyer's syndrome, partial and complete androgen insensitivity syndrome, and also severe hypospadias and atypical epispadias are included in that group. So how are DSDs assessed? Well, imaging actually forms a tiny bit of the assessment of patients with DSDs. The majority of the assessment is clinical, hormonal, genetic. A lot of psychological assessment, which is very important, and metabolic. But those few cases in which we do use imaging are really very important, and imaging is critical. So today I want to talk about what is the added value of MRI for DSDs. Well, we have diagnosis and anatomy, preoperative assessment, post-operative follow-up, and what is becoming a very interesting topic is the follow-up of dysgenetic gonads, retained dysgenetic gonads, and then in very complex cases where MRI is really superb. I'm not really going to talk about diagnosis and anatomy because I addressed that in my lecture last year. And if anyone is interested in that, those lectures are now available to anybody, even if you weren't at the courses, and you can get at those online. I'm mainly going to talk about the other aspects of added value. So, pre-surgical planning. Well, what do you need to know if you're going to operate on one of these patients? You need to know very clearly the anatomy. You need to know level of obstruction. You need to know a lot about the vagina. You need to know about the ovaries, other associated anomalies. And what would be nice is to know something about the function of the residual uteri, if there are any. So, anatomy. There are some things that are absolutely critical that your surgeon will want to know. This, for example, is a patient who's got a unicornuate uterus. So we have a relatively normal right uterine horn, which is, this is a terrible, it's floating all over the place. It's like I have no control over this pointer, but anyway, so we have a right-sided uterus, and you can see that uterus is unobstructed, and there's a normal cervix. In contrast, we have a functioning but obstructed left corner. And what the surgeon wants to know is how much of it is attached, and in particular if it's involving the cervix. If you have a tiny little attachment, this is a sort of half-hour operation where they literally just snip it off. A very long attachment means that there's a much longer operation and the morbidity is higher. Your chances of damaging the residual uterus is much higher. And if the cervix is involved, that makes it a very difficult operation because you're trying to preserve the integrity of the cervix for potential pregnancy at a later date. Another example where anatomy is very important is in septate uteri. As you probably all know, they're associated with miscarriage, and the current treatment is resection of the septum. However, the septum can be fibrous or muscular, and if they go in and resect a very muscular septum, they get a lot of bleeding and adhesions. And so they want to avoid doing this. And MR is actually very good at predicting what is fibrous and what is muscular. So in this example, I have a septate uterus, and you can see that this is close to the fundus, and at the fundus we have a muscular septum. But also right down as we extend towards the cervix, the septum is still muscular, and this patient really shouldn't be touched. Another case of a muscular septum, but a less extensive one, but all of this is muscular. There's no fibrous component to it. Whereas in contrast, in this patient, almost the entire septum is low signal and clearly fibrous. And in this patient, they can resect right up almost to the fundus of the uterus. So, you've got to identify the level of obstruction, which, as you probably know, can occur at virtually any level. And the rule of thumb is if there's a high obstruction, you get hematocolpos and hematometria. If you have a low obstruction, you get vaginal distension. The caveat to that is that your patient may be hormonally suppressed, and if they are suppressed, that can be very misleading, and you don't develop these the typical retained blood that you're expecting. So this is a patient with a very high vaginal obstruction, and you can see that the uterus, the corpus uteri, is obstructed. There's the level of the internal os, and the entire cervix and the upper vagina is obstructed. With high vaginal obstructions, it can be quite hard to define where the cervix ends and the vagina begins, because as a result of chronic distension, the vagina become quite thickened and fibrous, and they find that surgically. So this is an example of a very low obstruction where the entire vagina has distended up, and we have really quite a normal looking corpus and cervix uteri with relatively normal internal os. A patient with cervical agenesis. Now, rule of thumb says that this patient should have a distended uterine body, but they don't. And the reason they don't is because they have been hormonally suppressed for a long time, 6 months to a year. So pre-surgical planning, assessment of the vagina. Now, how the surgeon repairs or recreates or operates on the vagina depends very much on the length of the vagina and where it is and the size of the gap and so on. They have a number of surgical options, including direct anastomosis if you've got a good portion of vagina. If there's very little vagina, they do a bowel interposition, but those are becoming unpopular because you can sometimes get terrible colitis of the vagina, and the girls eventually opt to actually have the vagina resected. And a more recent development is they are beginning to do buccal mucosal transfers, so they create a tract and then they take mucosa out of the mouth and just do a plastic operation and coat the neovagina, and preliminary evidence shows that these are going to be much more successful than bowel interpositions. So you need to measure the vagina, you have to determine if a stenosis is present, you need to define the definition of the vagina from the perineum, what's the gap, and you need to be able to clearly recognize vaginal tissue and the level of the perineum, because you measure everything from the perineum. So we ask, is there a vagina there? Is there one? Is there two? How much proximal? How much distal? Is there a gap? Is there a transverse septum? All of those are questions that you have to answer. So what does the normal vagina look like? Well, it is collapsed as a structure. Normal vaginas do not contain any retained fluid. If there's any retained fluid there, it's your hint that there is some degree of vaginal stenosis. Now, Vaginas are either H-shaped or they're smileys, and this is an example of a smiley vagina. So you can see, I always think they look like little clowns. You see they've got a big nose there, which is the urethra, and a big smiley lip, that's the vagina, and then they've got the little eyes. And this is an enhanced clown. Again, his eyes, his nose, and his mouth. So there we are, clown vaginas. So how do you define the urethral meatus? Because the urethral meatus is where the perineum is. So if you find the urethral meatus, you know what level you can do your measurements from. So if you find the urethra and then just go down slice by slice, and then you hit this comma shape, so it's like a double comma, that is the level of the urethral meatus, and that is the level of the perineum. So it's quite a sort of critical thing to get your eye in for, to make your measurements from. This is an example of a double vagina where instead of the H or the smiley, we've got a couple of trefoils here. You can see the high signal in the center there from both vaginas. So the ovaries, why are the ovaries important? Well, they are frequently ectopic in Müllerian anomalies. In our own series of patients with Rokitansky syndrome, either one or both ovaries have been ectopic in up to 50% of patients, about 46%. You need to know where those ovaries are so that you don't go, when patients have complex anomalies, you don't want to damage them. And also for patients like Rokitansky, their only hope of having a child is with egg harvesting and surrogate pregnancy. So that you need to know where those ovaries are in order to harvest them. The most common sites for ectopic ovaries are either high at the pelvic brim, where they tend to lie anterior to the psoas, or low down, but very anteriorly and rather laterally. And we've got one patient with Rokitansky syndrome where both the small rudimentary uteri and the ovaries are just sitting at the internal inguinal orifice. So she was diagnosed as a complete androgen sensitivity syndrome because they sort of looked a bit like ectopic testes. But so you can find ovaries in quite bizarre places. So this is a patient with that septate uterus that we looked at earlier. So she has a normal right-sided ovary. And here you can see we're right at the pelvic brim. This is S1. And here is the left-sided ovary, way out of where you'd normally expect it to be. So finally, about pre-surgical planning, uterine function. Now, obviously, the function of the uterus is to become pregnant and carry a baby to term. But we actually are very poor at, we don't know what factors define an adequate uterus. I mean, we think it's probably size, morphology. We know it's something to do with endometrial thickness. And as Professor Tagashi knows herself, that there's a lot of information on uterine function which tells us about how a uterus is working and the motility. And so we think that motility is also very important in how a uterus functions. But it's actually very difficult to assess these patients because often if they're obstructed, they're hormonally suppressed, and so we don't know what is suppression and what is the fact that it's just a pretty rubbish uterus. And so another approach is to start challenging these uteri and imaging them. For example, you can challenge them and image the endometrium. An example of hormonal stimulation is seen in this patient with Swires syndrome. Now, Swires syndrome is where patients have XY, so they have male genetics, but they have streak ovaries, so they don't have testes, so they don't produce Müllerian inhibiting hormone, so they produce a uterus. So you have XY patients who are phenotypically female and they have a uterus. But they don't have ovarian stimulation. So this is a patient who had a very small uterus, patient with Swires syndrome, and she has had hormonal stimulation. You can see that she's now got really a very adequately sized uterus, and there's quite good development of endometrium. So this is potentially a uterus that could become pregnant with egg donation and in vitro fertilization. So the other thing we need to look at is other abnormalities, and there are a lot of them. There are a lot of associated abnormalities, the most common being renal and skeletal. Sometimes they're syndromic. The absent kidney is the most common, and this is often associated with ureteric anomalies. You want to know about these ureteric abnormalities because sometimes you have these obstructed ureteric remnants. And again, if someone's going to go in and deal with this complex surgery, complex anatomy, they need to know about it so they don't go chopping it. The other thing is that there's an increased incidence of ectopic ureters, and this can be a cause of incontinence. We've seen patients with insertion of ureters into the vagina, into low urethra, and that can cause incontinence. So this is a patient who has got a unilateral kidney, and she had a uterus didelphus with a left hemivagina and presented with obstruction. So this is the left-sided ureteric remnant. And you can see it's extending from quite high in the pelvis, but it has an ectopic insertion. This is the double vagina. This is the ectopic ureter, and you can see that it's actually full of blood. This is a T1 image, and it's full of blood. And this is because it's inserting into the vagina, which is itself obstructed. So you've got retrograde reflux of blood. Endometriosis. This is an example of a patient not with a uterine anomaly, but with deep endometriosis. Endometriosis is seen very commonly when they laparoscope patients with obstructed Müllerian anomalies, but in fact it doesn't appear to be a problem. If you relieve the obstruction, it just goes away, so they don't end up with significant clinical endometriosis once they become unobstructed. Adenomyosis can occur in an anomalous uterus like it can occur anywhere else, and we can see here this is a patient with bicornuate uterus and bilateral adenomyosis with thickening of the junctional zone and little areas of ectopic blood. So post-operative patients, well, uterine and vaginal surgery does have a relatively high failure rate, and the patients represent with recurrent pain and amenorrhea. And the most common problems are recurrent vaginal stenosis, and the other problem is in these patients with unicornuate uterus where they've had difficult operations, where you've been worried about the cervix, and you leave a little bit of functioning endometrium in the resected uterus, and they get recurrent hematometria. And in these patients, MRI is invaluable. So I'll show you a couple of cases. This is a patient who has had a colonic transposition to create a neovagina. And if you look here, we've got the bladder, the sagittal scan, we've got rectum posteriorly, and this is the neovagina. You can see it's surrounded by a huge amount of fat, and that is because the section of colon is brought down with a sort of big chunk of mesentery to maintain its vascular supply. So we can see that this uterus has got a distended body and cervix, and then the vagina looks pretty good in transverse section, but there is an anastomotic stenosis here at the junction between the cervix and the neovagina. In contrast, we have a patient here who's got lots and lots of hematosalpinx and a distended cervix and uterus. So here we can see that there is a stenosis between the cervix and the vagina. But if you remember, I said you don't get fluid in a normal unobstructed vagina, and what she had was a second stenosis. So in addition to that stenosis there, she had a more distal stenosis of the vagina, and this section here of the vagina, all the lower third of the vagina had stenosed up again, probably because it was not adequately perfused. So, dysgenetic gonads, they're becoming a bit of a hot topic because patients are requesting to retain their gonads. And a good example of this are patients with complete androgen insensitivity syndrome. So these patients are XY, they're phenotypically female, they have testes, but they have complete insensitivity to testosterone, so they develop as women. But they do have testes, and these can be sited either in the groin or in the pelvis. These ectopic testes have an increased incidence of malignancy. The disease starts as in situ disease and probably takes about a 7-year course to become invasive. But it's very hard to quantify that risk. Now, the old way of dealing with this disease was, or disorder, is that patients were allowed to go through puberty and then the testes were resected because of that increased risk of malignancy. In fact, what we're doing now is that we're finding that there's a whole bunch of women who now want to retain their testes. And they want to do it because it gives them a feeling of well-being. There probably is some non-specific effect of the testosterone. They don't require hormone supplements, so they don't have to take pills every day if they retain their testes. And they do somewhere in the back of their brains, they sort of hope that one day they will be able to use these testes for reproductive material, for genetic material for reproduction. So we're now left with this problem: is what do we do with people with retained testes that are potentially very malignant? So we have recently looked at our entire series of patients with CAS who have retained their testes, and we've characterized the appearance of the testes, correlated this with histology, and we've asked the question, can we detect malignant disease? So we have reviewed 46 testes in 25 patients, about half of which have still got them in, and then half of them decided to have them out after the age of 16, but after they had kept them in for a long time, relatively. So these retained testes were resected at the age of 24, a mean of 22. Our patients who've continued to keep their testes in are aged up to 39. This is our oldest patient. So what we see in these testes is they have nodules. You see nodules in around 60% of patients. And these nodules, these low signal nodules, are Congenital Adenomas. We also see ELF hats in a smaller proportion of patients. And this is the hyalinized pampiniform plexus. And you see cysts, which are paratesticular cysts. Some of them are clearly epididymal cysts in the majority of patients. So in 13 patients that did undergo gonadectomy, and you must remember their mean age was 22 years, 3 of these had pre-malignant foci. None of them had invasive disease. And 2 of these were intratubular germ cell tumours, and there was 1 patient with a sex cord tumour. 13 testes had germ cells within them, but these were spermatogonia and spermatocytes, so they weren't sperm, and these do not have reproductive potential. So this is an example of a patient with a retained testis, and this low signal nodule here is a Congenital adenoma, and you can see that actually they're scattered throughout the pelvis. And there we have our paratesticular cyst. And this is the thickened pampiniform plexus down here, which is the ELF hat. Now you might ask, why do I call this an ELF hat? And it's because this is actually an upside down ELF. If I turn him up the right way, you see there's his hat. So there's the ELF hat. There's his face, and there's his white beard. And the ELF hat, is this thickened, hyalinized pampiniform plexus with fibromuscular hyperplasia. And we've been through all our patients like this and sort of really done very detailed matching of macrohistology and histology. And so we really, we now really know what's going on in these testes. This is the patient, or one of the patients, that had ITGCN cells. So this is in situ disease, staining up with PLAP, which is placental alkaline phosphatase, a germ cell tumor marker. So what do we know about these dysgenetic gonads? Well, we know we can't detect in situ disease. They looked exactly the same as all the others. We don't know what is the necessary interval between follow-up. There's this feeling that probably they have in situ disease and then they suddenly fall off the cliff. So at the moment we're choosing to image them every year, but this may be inadequate. We may have to start to biopsy these testes in order to be able to identify when they have in situ disease, which would, if you develop in situ disease, we would recommend to the patient that they have them resected. There is some potential for developing special histology stains which might recognize early malignant disease. And we've just set up a European Working Party collaborative study where we're pooling all our patients with retained testes so that we can then have a longitudinal natural history study to actually work out what we should be doing with these patients. So the other place that MR is absolutely fantastic for is complex cases. Some of these cases are extremely complex. And I'm just going to show a couple. So here we have one patient who had spina bifida, exstrophy, she had uterus didelphys, she had adenomyosis, an obstructed left vagina, and a right vagina which was draining into the perineum, but not the perineum in the midline. It was really into the right buttock. So this is her image, and you can see it's really very complex. So these are axial scans. So this is the anterior margin of her superior pubic ramus, and you can see there's a large defect in her pubic rami. So this is the exstrophy. There's a very poorly formed pelvic floor muscle, and she has no coccyx because she had a spina bifida. Here we see a bit of bladder. This is part of the right-sided uterus, and this here is an obstructed left vagina. And you can see she's had surgery before. And on this slide you can see that this is now the right-sided vagina, and really it's just ending in the perineum at the common cloacal opening. When you get these cases, we see them in their teens, but of course these very complex cases have been looked after by the paediatricians for many years before we get them. But as children, the overwhelming part of their care is directed towards improving their musculature, dealing with their urinary problems and with their rectal problems in patients with anorectal atresia, for example. So we see them as teenagers when suddenly they start to either develop obstructed menstruation or when they start to talk about their reproductive potential. You know, am I going to be able to have babies? So by the time we get them, they've often had a lot of surgery. So unpicking the complex surgery from what is actually going on in their pelvis is extremely difficult. The other thing is that they do tend to have a poor outcome in terms of their reproduction because very often the surgery that they've undertaken makes it impossible to do laparoscopic surgery. They're at high risk for open surgery, and they are extremely difficult patients to look after. So the more information you can give your surgeon, the better. So another patient with complex anomaly is a girl who has a transplanted right kidney. She's got a dilated left ureter, and the reason it's dilated is because it's draining into the urethra, so she's incontinent. And she also had a septate uterus. So here we have this transplanted kidney. We have a septate uterus with a thick muscular septum. Okay, don't go anywhere near that with the laparoscope. And don't start chopping away that septum, you'll run into trouble. And then on the next slide, you can see this in cross-section. This is her distended ureter. And the reason it's distended is because it's inserting just down here, just below the vesico-urethral junction, and it's partially obstructed because the wall of the urethra is acting as a valve. But every now and then, her pressure was building up, and then she'd be incontinent. She was wearing pads and smelt when she came to the clinic. So does MR have added value? I think definitely. It's an absolutely fantastic tool in looking after these complex patients. Finally, I'd like to thank all of you for turning up so early in the day, and I'd like to acknowledge my co-workers in the DSD team because we very much function as a team, including Sarah Crichton, who's a paediatric adolescent gynecological surgeon, and our adolescent urologists Dan Wood and Chris Woodhouse. But there are, of course, many others. Thank you for your attention.